In Tune. Conversations on audiology and balance. An Inventis podcast.
Welcome to this new episode of In Tune, the Inventis podcast. Today we're talking about a truly fascinating topic, how we can listen to the brain in order to understand how we perceive sounds. To do this, we have with us Professor Stavros Hatzopoulos, who brings together medicine and engineering, a truly unique and remarkable combination. Associate Professor at the Clinical Department of Audiology and ENT, as well as Editor-in-Chief of the Autoacoustic Emission Portal at the University of Ferrara. Holds a PhD in Audiological Engineering from Worcester Polytechnic Institute, located in Massachusetts, and has achieved much more in the field. Thank you very much for being here with us.
Thank you very much for the invitation. I appreciate it.
Let's start with a bit of curiosity. If you'd like, could you tell us a bit about your background? How did this dual passion for medicine and engineering come about?
Actually, in the United States, they've already made this marriage quite a few years ago. They've combined medical research with mechanical and applied electronic engineering, and it's called biomedical engineering. So at the time, I was genuinely trying to be good, but I honestly didn't know exactly where to do my research for my PhD, which is the American doctorate that usually lasts about 5 years. I really wanted to focus on the eye, and that's where we ended up. There was no funding in the lab, not exactly on the eye. So I ended up researching the ear, which at that particular time I actually considered to be a much less important instrument, especially when compared to the eye. Obviously, I changed my mind. In the 90s, I completely changed my perspective on the subject.
It actually became a bit of a main character then.
The outer structure of the ear.
What led you to become interested specifically in auditory evoked potentials and especially in ABRs?
Basically, during my time in the United States, I had the valuable and unique opportunity to meet and interact with some distinguished American experts who were conducting this type of advanced electrophysiological recording on animal models that particularly interested me at the time. The most impressive thing was that it was, in many ways, practically a moment of true enlightenment, from the perspective that we could begin to understand, both beforehand and afterwards, what was actually happening in our brain from an electrical point of view. The engineer in me pushed the hearing scientists that we are now to say that this is a scientific method that tells us with a high degree of precision and accuracy exactly how cochlear post-processing occurs within the auditory system. In other words, once we move past the cochlea, what happens not at the cortical level, but at the broader brain level, which for me was
a turning point.
Yes. It was wonderful.
Love at first sight.
Now we're talking about the late 1980s when this happened. So at that time, BR was practically in its genesis, but it wasn't a fully applied method yet, as it became in the 1990s when there was a huge boom with screenings and other great developments.
Of course, and if you had to explain the ABR test to someone who isn't in the field, what does the test consist of? What does it allow us to understand exactly?
Well, the test is kind of like what happens when you're sitting in your car. You start up the engine and you basically hear a certain noise that tells you the engine is running. So what we really need to know is that the engine is actually working. How can we tell? Obviously, by carefully recording the ongoing activity of that engine, which in our particular case, the engine would actually be our brain, by picking up and monitoring its electroacoustic activity from certain very specific points, we can tell. So, by carefully placing tiny and specialized transducers, which we call electrodes, in specific locations within the brain, we can record the electrical activity, in other words, the neuronal activity, how neurons are activated or not activated, and how this activation progresses. This innovation is very important for us because it gives us an idea of how the brain creates the first phase of the acoustic scene.
How does it respond?
Exactly. So first we have the processing and decoding of everything in our inner ear, which we call the cochlea. But after that, we need to understand what happens next. With the Auditory Brainstem Response, or ABR, it's like putting the key into our car and turning it. By performing this test, we can understand exactly what is happening. Obviously, there isn't a sound that the brain emits at this moment, but it does emit certain very important electrical patterns which are repetitive and stable across all ages, all genders, all children, elderly people, pregnant women, everyone. And of course, not just humans, but animals too have this type of response, which is essentially the key to understanding, obviously, if the engine starts. After that, of course, we need to figure out a bit more with cortical potentials, but this is the part that tells us that something is there, that there is a response, that the system is working at this level.
And that already makes a difference.
It makes a difference.
In fact, in what situations is this test recommended? I mean, how is it performed? Is it an uncomfortable test? How long does it take?
Well, first of all, it's not really uncomfortable, okay, except maybe for women with especially beautiful hair. But aside from those rare cases, it's a painless, very easy and straightforward test, and it actually takes very little time. It is strongly recommended for any type of hearing or auditory problem because, as I mentioned earlier, along with other tests we perform, obviously standard audiometry tests, it gives us the ability to understand if there is a deficit, where it is, and how we can address it.
Where to intervene?
Exactly.
And from your point of view, what are the main difficulties in recording and analyzing ADR signals?
Usually the environment where the recording is done, for example, that's why it's not advisable to perform certain types of tests in an open field. Why is that? Because the signals we can pick up from our brain are really very tiny and quite small. We always have to make sure that these signals are not interfered with, for example, by interference from electric motors, other electronic devices, our cell phones, and things like that. So we have to perform this type of test in what we call an anechoic chamber, which is usually also shielded, a specially protected environment. The test is really very straightforward and easy. And we also provide our patients with a very comfortable, supportive chair so you can just relax. Close your eyes. It's truly a very quick test. We can say the same thing for people of all ages, but when we are working with very young children, we do encounter a bit of a challenge, mainly because they are not able to follow instructions like "now stay still for a minute." That just does not happen in reality. So in some cases, we have to give a mild sedative, which is a gentle medication, so that the child becomes calm and relaxed, and then we are able to perform the recording procedure successfully. This particular type of exam, fortunately for us, does not have any significant issues or complications with anesthesia, so we are able to use it to help calm down subjects who are not very cooperative.
Excellent. And how important is the ABR today in the early diagnosis of hearing disorders?
It's practically essential. It's essential to understand that in most situations for any type of hearing screening procedure we do, the ABR is the gold standard. It's worth mentioning that, of course, technology has certainly advanced over time. The classic approach, where someone comes to the clinic and we carefully place the electrodes and so on, still works well today. But now there are also much faster and more efficient machines that can perform evaluations, automatic screeners that we tend to use more frequently with children and newborns. In recent years, these technological improvements have made the process even more efficient, accessible, and comfortable for patients.
To get immediate responses as quickly as possible?
Yes, because one of our main issues, especially in the neonatal population, is that there is a particular form of asynchrony at the ABR level, which essentially means that something is not functioning correctly. It's called auditory neuropathy. If we do not have a tool like the ABR available, it is almost impossible to identify this condition. There is another test called otoacoustic emissions that gives us an assessment up to the cochlea, but without the contribution of an automatic ABR, it is impossible to identify this type of deficit.
Information is missing,
Exactly.
which are obviously necessary.
Exactly.
Is there a case or an episode related to ABR that particularly struck you and that you would like to share with us?
Well, yes, many years ago, a very dear colleague of mine brought me his daughter and said, "Listen, my daughter is 14 years old. I really don't know what to do. I see that she doesn't respond much to sounds." Let's remember that at 8 months of age, children should respond to various sounds in their environment, especially with their mothers. We did a quick and automatic ABR. There was a trace of a response. We also did autoacoustic emissions. So at that point, I said, yes, I don't see anything out of the ordinary.
And yet,
We had to wait about 6 months, and 6 months later, that response had practically disappeared. It was a form of genetic deficit. Of course, the girl later received a cochlear implant, and now, obviously, she functions very, very well in the real world. 6 months later, there was truly no trace of the response in the right ear, so it was a very stressful situation, yeah.
I can really imagine, especially if they're friends or people you're close to.
Especially in the medical field, it was, to be completely honest, somewhat embarrassing for us that we hadn't realized it earlier.
Here too, the ABR was helpful with the test, the retest, and also with ongoing monitoring over time.
The thing is, in these particular cases, the strange part is that within about 3, 4, or even 5 months, it just seems to disappear. So if you don't begin with a full clinical ABR, because in my friend's case, we had only done an automatic ABR, which is a basic screener that doesn't really give you much information. The crazy thing is that after just 3 or 4 months with this kind of deficit, you basically don't have any waves left. All of a sudden you think, my God, I do the ABR even at the highest levels, 90 decibels, and I still don't see anything. At that point, it's absolutely really, really stressful.
And when we talk about responses, what kind of information are we looking for in an ABR?
So, the information we're basically looking for comes in 2 main categories. The first type is the overall shape of these well-known and characteristic patterns in the ABR, which are called the ABR waves. There are 5 of these waves that we use out of the 7 that can potentially be recorded. And what we need to understand there is exactly where, in terms of timing, these waves are located, which are very specific for each age, each gender, and so on. And this information, particularly when combined with other tests, tells us whether we have conductive problems, cochlear problems, or retrocochlear problems. This way, we can clearly differentiate the potential origin of the deficit that we need to address.
Very important information.
Very detailed information. Obviously, it takes some time to start understanding and practicing it, and usually you also need other things. So the ABR alone doesn't really light up the entire path for us. We have to do other things as well in addition to that.
Absolutely. And how do you envision the future of ABR and more generally of audiological diagnostics?
There, what we can think of are 2 letters, namely AI, or artificial intelligence, which we all hope will also become an important and valuable part of diagnosis, in the sense that we can train it with various pathologies so that the machines can easily read, interpret, and immediately recognize or suggest that this is, with a certain probability, this type of condition. To direct and guide. Obviously, this can create some bias, but in my opinion, we've been doing ABR since the 1960s, and we have a high level of know-how and expertise. From the perspective of us professionals, I mean the field as a whole, the know-how is exceptionally high. The issue would be whether, with this type of software, we can actually achieve results in less time. So being able to see things much more quickly, or to have suspicions that lead us to perform other types of exams without wasting any valuable time.
Time is very crucial.
Especially if we are talking about retrocochlear cases where there are many doubts and uncertainties, And usually, for example, you need to do some kind of MRI. So right away, you can understand that this is a very important possibility, and you can immediately request a more detailed type of exam, obviously imaging.
Of course. So do you expect a much more technological future, much more
Technological with many, many notable innovations, particularly at the software level.
Absolutely. And so you already experience this every day and also hope to continue improving this future through collaboration between medicine and information technology.
Absolutely, absolutely, yes, without a doubt, that's certainly true.
What can I say? Thank you very much, Professor, for introducing us to the world of ABR and showing us how medicine and technology can work together. We hope this episode has piqued your curiosity and helped you understand how important it is to take care of your finger. Many thanks again to Professor Stavros.
Thank you for the invitation.
Thank you very much to you, and thanks to everyone for listening to us. See you next time.